So starting with hypertrophic cardiomyopathy, so it's a common genetic heart disease. As you all know, it is a autosomal dominant condition. So it is an autosomal dominant condition, and it is mostly seen in the males. So male has more prevalence when compared to females, and its prevalence is said to be around 1:200 to 1:500.
Just give us a minute.
Okay. Yes. Sorry for that. There was a technical problem, I think. So now am I audible to everyone? So we'll be talking about hypertrophic cardiomyopathy today. So hypertrophic cardiomyopathy is one of the most common genetic heart diseases, and it is an autosomal dominant condition. It is most commonly seen in males more than females, and its prevalence is said to be around 1:200 to 1:500. The most common site which is involved in the heart is the anterior basal septum. So suppose we take this as the left ventricle. So the basal part. So this is the basal part is there, which is the most commonly involved in hypertrophic cardiomyopathy. And there can be isolated location of other places as well, as like apex can be involved or only the mid cavity can be involved and all. But most commonly it is seen in the anterior basal septum. Apical part is most commonly seen in Japanese, and it is also called as Yamaguchi syndrome. And in some patients, like around 13% of population, as stated here, it is biventricular hypertrophy. That is both left ventricle as well as right ventricle is involved. So in few cases, both left ventricle hypertrophy and right ventricle hypertrophy is seen, and which is seen in 13% of patients. This is a term which is commonly asked in your practicals also. Examiners find it very often they ask these questions that in how many of patients you will see biventricular hypertrophy. So the literature says that around 13% of the population of hypertrophic cardiomyopathy will have both left ventricle as well as right ventricular hypertrophy. Also, another common question which they ask in our Viva is what are the common syndromes which is seen associated with the HOCM, and commonly it is said to be the Leopard syndrome and the Noonan syndrome. So this comes into very importance when we do, like, suppose you're taking a case history of HOCM, general examination play a role here, and they may ask that when you are examining the patient during general examination, what will you see? So you have to then be aware of both this Leopard and Noonan syndrome, so that then you can answer properly that you will be looking for these features in patients in general examination. So patient with Noonan syndrome will have a short stature and they will have a webbed neck, as you can see here. This is the webbed neck. There will be pectus carinatum, as you can see here as well, and apparently low set nipples. So all these features are present in this child, and these are the features of Noonan syndrome. And this we should be aware, so that whenever somebody asks you during HOCM case presentation, that these are the features we look for in general examination. Suppose we get a case of HOCM. Similarly, Leopard syndrome is another type where we see Noonan syndrome plus skin lentiginous will be there. So this is the addition feature, that is skin lentiginous we can be seen. Along with all the other features of the Noonan syndrome as we discussed, we will see this skin lentiginous in the Leopard syndrome. So coming to the actual definition, it is actually defined as asymmetric septal hypertrophy. So any septum which is, if it is more than 15 mm, and it should be asymmetrical. Asymmetrical means, what do you mean by asymmetry? Is that suppose this is the left ventricle. So if all the part of the left ventricle is uniformly hypertrophy, like the thickening is there uniformly around all, then it is not called as asymmetric septal hypertrophy. It is called as a concentric hypertrophy. Asymmetric septal hypertrophy means only one part of the ventricle. So if only one part of any one part of ventricle is hypertrophied more than the other part, then it is called as asymmetric septal hypertrophy. And usually they say that if the ratio between, so usually we talk about is the, suppose if this is the ventricle and this is the base part and this is the posterior wall. So basal to, so basal top to septal ratio, if it is more than 1.3:1. So suppose the septum is around 1.3 times thickened when compared to the posterior wall, then it is actually labeled as asymmetric septal hypertrophy. So minimum of the septum thickness, any part of the septum thickness should be more than 15 mm. And suppose if there is a positive genetic history, suppose family history of positive genetic testing is there, then even 13 to 14 millimeters will be labeled as a septal hypertrophy. That is asymmetric septal hypertrophy in that case. So it is divided into two types, that is hypertrophic obstructive cardiomyopathy and hypertrophic non-obstructive or a plain hypertrophic cardiomyopathy. So hypertrophic obstructive is more common, as you can see. It is said 3/4 of patients, that is 75% of the patients will have obstructive HCM and 25% will have a non-obstructive HCM. So coming to the pathophysiology part, which is very important to know that how does this hypertrophic obstructive cardiomyopathy causes the symptoms and all. So to know that, we should know some basics of anatomy here. Like suppose this is the ventricle, and if you take complete heart like this, so these are the atriums. Okay. So we make a diagram here. So this is the left atrium, left ventricle, right ventricle, and right atrium. So generally aorta arises from this part. So you can see here aorta. So suppose there is hypertrophy of this left ventricle, this may actually obstruct this left ventricular outflow. So this flow will be obstructed by the thickening of this. So which is a most common symptom, that is left ventricular outflow tract obstruction, which is seen in 75% of patients with HCM. And there are two mechanisms, as first we have already discussed. One is the septal hypertrophy. So septal hypertrophy will occlude this part. So septal hypertrophy will occlude the LVOTO, which is the most common effect is seen. Also, the septal hypertrophy, what does it does that the mitral leaflets arise from this part. So this is the anterior mitral leaflet, and this is the posterior mitral, anterior and posterior mitral leaflet. So because of this obstruction, when the blood flow goes in this direction, because of this pressure and all, there will be dragging of, which is called as Venturi effect. There is a dragging of the anterior mitral leaflet towards the septum, so which is called as systolic anterior motion of the leaflet, which is basically because of the Venturi effect. And this is important to be remembered, because this is also frequently asked in your exams in Viva, is that what is the reason for the systolic anterior motion of the leaflet? And then you have to be aware that this is called as Venturi effect. So because of this narrowed pathway from where the blood has to go, it creates a physics dynamics, and which drags the anterior leaflet towards the septum and produces the systolic anterior motion of leaflet. Similarly, then, which is the most common cause of left ventricular outflow tract obstruction. Also, in few patients, there is anatomic alterations in mitral leaf valve. So this is a mitral valve. So normal mitral valve itself, what they say is there can be presence of congenitally longer leaflets. there can be presence of longer leaflets, as well as there can be anterior displacement of the papillary muscles. So because of this longer leaflets and anterior displacement of this papillary muscles also, there is a drag towards the septum, which can cause the left ventricular outflow tract obstruction. So gradient wise, what they say is if the peak LVOT gradient, so peak LVOT gradient, if it is more than 30 millimeters of mercury, then it is labeled as hypertrophic obstructive cardiomyopathy. And if the gradient is around more than 50 millimeters of mercury, then it is considered to be a threshold for septal reduction surgery. So which will be going on during our treatment part. We'll discuss about the septal reduction in more detail. So important thing also to remember is that LVOT obstruction is a dynamic in it. So there is a dynamic hypertrophic obstruction, and it is sensitive to ventricular load and contractility. So knowing this pathophysiology is very important, that how each of these factors, that is the dynamic auscultation or preload, afterload, and myocardial contractility, how does it affect that? So we'll go through it one by one. So suppose we take this left ventricle again, and suppose this is the aorta and outflow tract is there. So this is the outflow tract. If you see, this part is the outflow tract. So because of the hypertrophy, what will happen is that suppose there is decrease in preload. So what does preload means? That preload is the amount of blood which is reaching to the left ventricle or any ventricle. The amount of blood which we reach to the ventricle is called the preload. So now if the preload is less, suppose the amount of volume which is coming to the left ventricle is very less. So that means what? That means that the ventricle is not able to stretch much, and then this septum will come more closer to the LVOTO and will lead to more obstruction. So it means that if there is decrease in the preload, that means more will be the obstruction and more will be the LVOT gradient. Similarly, suppose there is increase in preload. So if there is increase in preload, it means that more blood will come into the left ventricle. This more number of ventricle, now it will lead to what is called as ventricular stretch. So because of more blood, ventricle will stretch more, and this will move this septum away from the LVOTO, and there is decrease in the gradient in there. So more is the preload, more will be the stretch of the left ventricle, and the septum, this hypertrophic part will move more away from the left ventricular LVOTO, and this will roll to what is called as decrease in the gradient. So similarly, next coming to, so overall what do you mean that if the volume inside the heart is less, so suppose the less amount of volume, less is the ventricular stress, and more will be the septum occluding the left ventricular outflow tract, and this will be more will be the gradient. So anything which decreases the volume of ventricle, volume of left ventricle, will lead to what is called as increase in the LVOT gradient. Similarly, now if you take afterload into consideration, so suppose, so similarly, so what is afterload is that suppose this is again we're drawing the left ventricle and this is the outflow tract here. So what do you mean by afterload is that afterload means nothing but is the resistance against which the heart has to pump. So resistance is nothing but the resistance from the peripheral vascular resistance. So suppose more is the resistance of peripheral vasculature, more the heart has to work. So lesser will be the emptying of the heart. So if the resistance is more, the amount of blood emptying from the left ventricle to the LVOTO will be less. So what does that mean? That more amount of blood will again stay into the ventricle, and this ventricle volume will stretch the left ventricle, and this hypertrophied septum will move away from the left ventricular outflow tract, and thus it will be decreasing the gradient. So again same, so if suppose there is decrease in afterload, what do you mean by decrease in afterload? Means suppose there is decreased resistance, then what will happen is more amount of LV will be emptying. That means decreased volume inside the heart, and then this septum will have less stress and it will be occluding the left ventricular outflow tract, and thus it will increase the gradient. The third thing which comes into picture is the increased myocardial contractility. So it is very clear that suppose there is more contraction of the ventricle, so more ventricle part will contract and will come more closer inside the cavity, and it will be occluding the left ventricular outflow tract, and thus this will increase the LVOT gradient. So next, coming to the mitral regurgitation in HOCM, there are two mechanisms which is explained. One is because of the left ventricular outflow tract obstruction, and second is the primary leaflet abnormality. So primary leaflet abnormality and LVOTO obstruction. So as we have already discussed, LVOTO obstruction. So what does it does is, so suppose this is your outflow tract and this is the septum if it is there. Because of the obstruction and because of the Venturi effect, what will happen? There will be drag of this anterior mitral leaflet towards the septum side. So instead of it closing here, it moves more towards that. So there will be lack of coaptation of the anterior mitral leaflet and the posterior mitral leaflet. So this both leaflet won't be able to come closer. And since there is no closure, the blood will leak back into the left atrium, and it is called as mitral regurgitation. And this is the most common mechanism which is causing the mitral regurgitation in HOCM patients. Second is the primary leaflet abnormality. As we have already discussed, that there is a longer leaflet length and anteriorly displaced papillary muscles or anomalous papillary muscle insertion. All these things are also responsible for what is called as the mitral regurgitation in this one. So this is seen in around 20 to 30% of patients is primary leaflet abnormality. So diastolic dysfunction, it is the most common cause of dyspnea in HOCM patients. So dyspnea. So it is the most common cause of dyspnea. So what happens is in diastolic dysfunction is any heart has two components. One is the contraction capacity and second is the relaxation property. So now because the ventricle is unevenly hypertrophied and there is left ventricular outflow tract obstruction. So what will happen is that the ventricle has to work more against this resistance and there will be stretch of this ventricle. So more stretch, that means there is one, first is high intracavitary pressure because of the obstruction, this pressure is high, there will be stretch of this ventricle. The stretch leads to what we call as decrease in relaxation or impaired relaxation of the heart, and thus it leads to what is called as diastolic dysfunction, and it is the most common cause of dyspnea in patients with HOCM. Coming to myocardial ischemia, another pathophysiology is ischemia is again basically because of the same phenomena, because there is septal hypertrophy. The septum is unevenly hypertrophied, that is asymmetrical hypertrophy when compared to the other part, and there could be what is called as perfusion mismatch, because this part will have a more demand of oxygen and the perfusion may not be that much to supply this part, and then could be perfusion mismatch, and this is what we'll call as, that is mismatch between the myocardial oxygen supply and demand, and this will lead to patients with chest pain. Also, there is found to be a microvascular dysfunction and also a impaired coronary flow reserve here. Another important thing is the myocardial bridging. So what is myocardial bridging is that normally in any myocardium, the coronaries are present above the myocardium. So suppose coronaries are present here in above the myocardium. So it is not present beneath the myocardium. So in few patients, what happens is that suppose this is the coronaries and this myocardium is now present over to that. So the vessels are inside the myocardium. So when the coronaries are inside the myocardium, what will happen is that during the contraction of the ventricle, this contraction will lead to narrowing of this vessel. So now since the coronary artery is narrowed here, during each contraction, what will happen is that it is blocking, it is causing stenosis of the coronary artery, and this will lead to what is called as angina or ischemia. And this is called as myocardial bridging. In normal patients, it is seen in 25% of adult patients, it is normally seen, whereas in HOCM patient, it is seen in around 41% of patients. So patient coming with chest pain in HOCM, you should definitely rule out myocardial bridging. So another important thing is the autonomic dysfunction, which is also commonly seen in patients with hypertrophic cardiomyopathy. There could be impaired heart rate recovery and inappropriate vasodilation. It is seen in around 25% of patients. So next, coming to the natural history of HOCM, it can be present from any age, from infancy to old age. Normal mortality is found to be 1% per year, and 23% of patients live at least 75 years. And mean age of death is said to be 56 years. So these are all important to remember, mainly because these are frequently asked in your practical exams as well. So the most common cause of death in hypertrophic cardiomyopathy is sudden cardiac death, and this sudden cardiac death is mainly due to ventricular arrhythmias. So arrhythmias is the most common cause of sudden cardiac death, and another causes of sudden cardiac death in patients of HCM is heart failure and stroke. So usually if the patient is young, in young patients, normally arrhythmias are the most common cause of death. But since with increase in age, what happens is that the ventricle, because there is too much of load on ventricular, because of the obstruction, the left ventricle has to work more and more to pump blood. So what happens is that the muscles also, after some limit, they get tired, or what is called, like, they get burned out. So burned out HCM, there's another terminology called as burned out HCM, which means that normally there is hypertrophy of the ventricle, normally seen in case of HOCM. Whereas in burnt out HCM, this is a terminal stage of HCM where, because of this increased load on it and decreased supply, the perfusion becomes lesser and lesser, and this muscle get very much thin. So there will be thinning of the muscle, and it will lead to what is called as decrease in ejection fraction as well. So burned out HCM is a terminology which is commonly used for that, and this is the another major cause of dyspnea in patients with HCM, and usually seen in elderly patients. And this is also one of the common cause of death. So here the treatment is nothing. Only thing available for burned out HCM is the heart transplantation. So another cause of death is the stroke, which is basically because of the atrial fibrillation, which is seen commonly in patients with HOCM. So why atrial fibrillation is common is that, again, suppose this is the left ventricle and this is the left atrium. So now, since there is diastolic dysfunction, there is impaired relaxation, the atrium is unable to empty the blood inside the ventricle. And also there is mitral regurgitation. So blood will going back. So atrium is not able to empty, as well as the ventricle is sending back blood to the atrium. So this will lead to what? Increase in the load at the left atrium level. So this left atrium now will get stretched more and more. So stretch of my atrium will lead to formation of ectopic foci, and this may generate what is called as ectopic arrhythmias and atrial fibrillation. So this atrial fibrillation, any atrial fibrillation, since the contraction will not be that effective, so this may lead to chances of increased clot formation, and patient may land up with stroke, and this is usually seen in elderly patients. So both burned out HCM and atrial fibrillation is commonly seen in elderly population, usually seen in older than 65 years of age. So as I've already discussed, this SCD is sudden cardiac death is uncommon in young children and very uncommon in older than 60 years of patients. So coming to clinical presentation, heart failure, variable degree of heart failure can occur, and as we have already explained, the most common cause of heart failure is first is the diastolic heart failure, and then it is followed by the systolic heart failure, which is called as burnt out HCM. So this is the Burnt-out HCM, that is the end stage of hypertrophic cardiomyopathy, and is characterized by myocardial fibrosis, and it lead to left ventricular wall thinning, and UGF will be less than 50%. Usually ejection fraction is quite high in patients with HCM, is usually more than 70%, basically because since there is obstruction, the ventricles start to contract more and more to pump blood out, and the ejection fraction is usually high. But in burned out HCM, you will see that if EF is less than 50% in any patient of HOCM, you should suspect burned out HCM, and it carries a very grave prognosis. So it is refractory to medical therapy and requires cardiac transplantation. So myocardial ischemia also, as we have already discussed before, it is basically because of the microvascular angina, that is supply or demand mismatch. Another common symptom which is commonly seen in HCM is syncope, which is seen in 15 to 25% of patients. Various mechanisms can be there. Syncope can be because of the cardiac arrhythmias. So as I've already said, arrhythmias is very common in young patients, and that too ventricular arrhythmias. So this arrhythmias is the most common cause of syncope. Also, there is autonomic dysfunction. in HCM. So this autonomic dysfunction can also lead to what is called as vasovagal syncope. And also there will be postural hypotension because of this autonomic dysfunction. So atrial fibrillation, as I've already discussed, it is the most common arrhythmia which is seen. It is usually prevalence is seen to be 20 to 25%. Its incidence increases with age because it depends upon the left atrium stretch and all. It takes more time for the left atrium stretch and all. So it's commonly seen in elderly patients and not seen in young patients. So ventricular arrhythmia, the most common arrhythmia is the VPCs, which is seen in 80% of patients, and non-sustained ventricular tachycardia is seen in 25 to 30%. So what is meant by non-sustained ventricular tachycardia is if any VT, that is ventricular tachycardia, if it is less than 30 seconds. So if it sustains for less than 30 seconds, then it is called as non-sustained ventricular tachycardia. So let's go to investigations. Like most common investigation we see in HOCM patient is first is ECG. So classically, for classical asymmetric hypertrophic cardiomyopathy, if there is asymmetric hypertrophy, since there is left ventricular hypertrophy, septum hypertrophy is there, there will be LVH. So in ECG, there will be LVH criteria will be present. That is the dominance of the V5, V6 and 1 AVL. So dominant R wave will be seen in this V5, V6 and 1 AVL. There are various other criteria which we'll go through in our next class. This may not be, because the time may not be sufficient for us to discuss everything in this class now. So there will be left ventricular hypertrophy because of the septal hypertrophy. And also important thing is that there will be Q waves. So if this is the R wave, QRS wave, there will be the deep Q waves will be seen in hypertrophic cardiomyopathy. So why this deep Q waves is there? So as we all know, so suppose this is the heart. So this is the right atrium, this is the right ventricle, left atrium and left ventricle. And this is the positive electrode which is kept at the left, that is the left lower limb. So normally the direction of flow is from SA node to AV node. The action potential go from SA node to AV node in this direction. Since the direction is from this direction to this direction towards the positive electrode, we get a positive P wave. Then the conduction goes from AV node to the septum. So suppose we take only septum here. So suppose you take only septum. So we are talking about the septum and the left ventricle here. So after from here to here, that is after the P formation and the PR interval. PR segment is basically because of the time taken to cross from the AV node. Now in the septum, what will happen is that the direction of flow is from the left side of the ventricle to the right side of the septum. So depolarization go in this direction. So since the depolarization goes in this direction and the normal positive electrode is toward this direction, it is against the opposite direction, we get a small Q wave here. So this is the Q wave. This is a small Q wave. So when the Q wave is more than 2 millimeters, it is called as pathological Q wave. So why we are getting a pathological Q wave in HCM is that there is asymmetrical septal hypertrophy in case of hypertrophic cardiomyopathy. So the septum will be very much hypertrophied, and that's why the voltage generated by is very high, and thus we get a deep Q wave. So deep Q wave can also be seen in patients with prior MI. Suppose the patient have a prior MI, that patient will also have a deep Q wave. So how will you differentiate is that, suppose if the Q wave is less than 40 milliseconds in duration, then it is said to be because of hypertrophic cardiomyopathy. If it is more than 40 milliseconds, then it is because of the prior ischemia, prior MI. So less than 40 milliseconds means nothing, but suppose if it is less than 1 small square in ECG, then it is said to be because of HCM. So you can see here in inferior leads, you can see here deep Q waves, and it is not occupying more than 1 small square. And these are the more features of what is called as hypertrophic, that is hypertrophic cardiomyopathy, and deep Q waves you can see here. Also you can see usually it is seen in the inferior leads and the lateral leads, as you can see here. So if the infarction QS will have typically more than 40 milliseconds and HCM will have less than 40 milliseconds. And lateral Q waves are more common when compared to inferior Q waves. So other variety is called as apical variant and also called as Yamaguchi syndrome, since there is only apical hypertrophy. So there is apical hypertrophy only. So this part is only hypertrophied. Apical part is there. So since only apical part is hypertrophy, the apical part, the leads we get is the V5 and V6. So since V5 and V6 is there, so any ECG in that part will have a dominant R wave, and also there will be giant T wave inversions. You can see here there is dominant R wave in the V4, V5, and V6, followed by dominant T wave inversions. You can see here. So these are the characteristics of what is called as Yamaguchi syndrome. So what are the other features you can see in case of ECG is that there can be a left atrial enlargement. So as I've already discussed, in elderly patients, what happens is that because the ventricle is non-compliant and also there is mitral regurgitation, more blood will go into the left atrium and there will be stretch of the left atrium and dilatation of left atrium. So left atrium dilatation means it will produce what is called as P mitral picture. So this P mitral is commonly seen in elderly patients. Also, there is many of the patients will have a short PR or delta wave called as WPW syndrome, which is seen in 33% of patients. So it varies from various literatures. One of the studies has shown prevalence of 33%, but the actual prevalence is usually found to be around less than 10%. And in ECG, you should also look for any other arrhythmias if it is present, like atrial fibrillation or supraventricular tachycardias, ventricular premature contractions, or ventricular tachycardias. Next, coming to echocardiography, as the most important things to remember is the septal to posterior wall thickness. So as I've already discussed that this is the septum, you can see here, this part is the septum here. So you can see septum is very much thickened here. So this is the thickening of the septum, and you can see the posterior wall is very small. So suppose if the septum to posterior thickness, if it is ratio is more than 1.3:1, it is favoring asymmetric septal hypertrophy. But not to forget, there are other causes also where there could be mismatch between the septal and posterior wall. That is most important, is called as posterior wall MI. Suppose there is posterior wall MI or ischemia. Obviously, this left ventricle, this posterior wall, the thickness will be less because of the ischemia, perfusion will be less, and there will be thinning of the posterior wall. So there could be mismatch. So you have to definitely rule out posterior wall MI before labeling any patient as HCM. Another important is that suppose there is associated right ventricular hypertrophy. So suppose any patient of pulmonary hypertension, if there is dilated right ventricle, so right ventricle is also in this part only. So now if this right ventricle is also hypertrophied, so this may appear that the entire septum is hypertrophied because of this right ventricular hypertrophy. So secondary causes of right ventricular hypertension has to be ruled out. So suppose if there is associated RA and RV dilatation in many patients is there, then you should be very careful in labeling patient as hypertrophic cardiomyopathy. So by the way, this is a parasternal long axis view. You can see here, this is the left ventricle, this is left atrium, this is the anterior mitral leaflet, this is the posterior mitral leaflet, aorta, this is septum, and this is the RVOT. You can see here again, RVOT and left ventricular septal thickness is very high here. So another important thing is, as we've already discussed, there is systolic anterior motion of the mitral valve. So how do you assess that in echo is that, so while we take the echo, so you can see here, this is the parasternal long axis view. Suppose similarly, this is the parasternal, you take a normal parasternal long axis view, and at the level of mitral valve, you put a M mode. You put a M mode here. So when you put a M mode, you get an appearance of this. So you can see here, these are the anterior leaflets and these are the posterior mitral leaflets. So posterior mitral leaflet both are there, and SAM can be graded based on their proximity to the septum. So there is one gradient which is mentioned that there are 4 grades of SAM. Grades of SAM. Grade 1 is said that there is no approximation, there is no attachment of the IVS with the anterior mitral leaflet. So anterior mitral leaflet and IVS is not attached to each other. Suppose, so this, if it is a hypertrophy, suppose this is a septum and this is the mitral leaflet, and this is the posterior mitral leaflet. This mitral leaflet will be there, but there will be no attachment to the actual septum. So there will be a gap. So this gap is usually said to be more than 10 millimeters in grade 1. Suppose there is no contact between the septum and the anterior mitral leaflet, but the gap is less than 10 millimeters, then it is called as grade 2. And suppose now if the anterior mitral leaflet is attaching to the septum, but it is attached only during less than 30% of systole, it is called as grade 3. And suppose if it is attaching for more than 30% of systole, then it is called as grade 4. You can see here grading is there. Grade 1, no mitral leaflet septal contact, and the distance is less than 10 millimeters. That is more than 10 millimeters. Second is less than 10 millimeters. Less than 30% of systolic time is grade 3, and more than 30% of systolic time is grade 4. And LVOT gradient has to be assessed in apical 5-chamber view. The apical 5-chamber view, I'll show you that. So how does it appears is, this is the classical HOCM. You can see here, so this is the 5-chamber view. The 5-chamber view will be visible like this. So this is the atrium. So this is the 5-chamber view, which will be visible in the echo, and you have to put a continuous wave Doppler here along the LVOTO. So after doing that, you get this classical sky dagger, which is called as sky dagger phenomena, where you can see here that there is slowly rise in the velocity or the gradient here, and there will be stoppage here. Now what happens is that now, since the left ventricle starts emptying, what will happen is that the septum will try to occlude this part. So septum will come more closer to the LVOTO since it is emptying now. So during this part, the left ventricle will try to pump blood against this resistance, and it will contract even more and try to send blood here. So thus there will be some deflection here, and it will give it classical phenomena of HOCM. However, you can see in aortic stenosis that it is how much smooth. You can see here, it is very smooth here. So there is no deflections like that. Whereas here, because of the dynamic auscultation, you can see a deflection here. So this is classical of what is called as left ventricular outflow tract obstruction. Another thing is called as Brokenberg phenomena, which is seen in echo as well as in cath study. So Brokenberg phenomena is nothing but, suppose patient get a VPC. So during VPC, what happens is that the ventricle will not be contracting too efficiently. So what will happen is that all the blood will be stayed here, and during the next beat, so next beat to VPC, whenever there is normal contraction is there, this normal contraction will have a forceful contraction. When compared to the previous contraction, this contraction will be very forceful. So what will this lead to is that because of this forceful contraction, what will happen is that the outflow tract, so suppose this is the outflow tract, because of the forceful contraction, there will be more obstruction to the LVOTO, and there will be increase in gradient. So you can see here, there is increase in gradient here in the Brokenberg phenomena. So coming to echocardiography guidelines, what does ESC guidelines is said that if a patient is diagnosed with HCM, they have to do repeat echo at every 1 to 2 years. For patient, suppose a patient has a HCM and resting LVOT gradient of less than 50 millimeters of mercury, you can do a provocative maneuvers can be used. So what is the most efficient way to do a provocative maneuver? So that is the Valsalva at bedside. How will you do that? So while doing an echo on any patient, what you have to do is you have to put your hand on patient's abdomen. So you put your hand or resistance on the patient tummy, and you have to ask the patient to lift his abdomen. So lift his abdomen against the resistance. So by breathing, he should try to lift the abdomen against the resistance of your hand. So this will generate a Valsalva, and this is the ideal method to do Valsalva maneuver at bed. And this is this commonly is asked in the exams as well by the examiners. They ask frequently that how do you assess or do a physical maneuver or Valsalva maneuver at bedside. So role of cardiac MRI. Cardiac MRI is very important. Why? Because suppose this is a myocardium. and left ventricle is there, and because there is hypertrophy in this part, there is also a perfusion and supply mismatch. So suppose there is perfusion supply mismatch, what will happen is slowly there will be ischemia and there will be formation of scar here. So there will be development of scar here, and this scar can generate what is called as scar VT or arrhythmias. So in cardiac MRI, what we do is we give gadolinium, that is the contrast. This gadolinium is taken up by the fibrosed myocardium, and it is not taken by the normal viable myocardium. So if the fibrous myocardium takes the gadolinium, amount of gadolinium enhancement, we see the gadolinium enhancement, how much is there. Suppose if this is more than 15%, that means that there is significant scarring, and this will be a high risk of arrhythmias, and these patients are indicated for ICD therapy, that is defibrillator therapy. So you can see here there is scarring, you can see here an enhancement of this, all this whitish part you can see here. These are all scarring and all. So this is amount of scarring is very important to rule out the myocardial fibrosis. And this is cardiac MRI mainly role is for the risk stratification. So next is heart rhythm assessment. So when to do, so what we say is ECG should be done in all patients and every follow-up every 1 to 2 years. And you should do in patients with HCM, you should also do ambulatory, that is Holter monitoring, or 24 to 48 hours continuous ECG monitoring has to be done to look for any NSVTs or arrhythmias if they are developing. So why this is important is that suppose a patient is developing NSVT or sustained VTs during a period when during this Holter monitoring, then this is also an indications for what is called as ICD therapy or defibrillator therapy, and there is high risk of sudden cardiac death. So that's why this patient should be undergoing, all the patients of HCM should undergo at least once they should undergo a Holter, and it should be due periodically every 1 to 2 years. So role of cardiac catheterization in HOCM, there are 4 characteristic findings which see in HOCM is that spike and dome configuration. So spike and dome configuration is nothing but early spike. So normally there will be early spike will be there in left ventricle, basically because of the left ventricle emptying. So if this is left ventricle, so if this is aorta, because of the initial emptying, there will be spike. You can see here, this is the spike. So now what happens is when the left ventricle is emptying, there will be more and more septal hypertrophy, and this septal hypertrophy comes and occlude this left ventricular outflow tract. And thus there will be initial some obstruction like downgrading of the pressures, and again you can see a spike here. This is called a spike and dome configuration, and this is classical of HOCM. And more classical one is called as Broken-Borough-Braunwald-Morrow sign, which is seen in patients followed by VPC. So suppose a patient develop a ectopic beat or a VPC. So now the post-ectopic beat, whenever the heart is contracting, the heart will contract with more force. So post VPC, there will be more time for the heart, and it takes more force. There will be increase in contraction or force of the myocardium. So if myocardium contracts more, it will come more closer and it will obstruct the what is called as left ventricular outflow tract. So during this post VPC beat, whenever there is left ventricle is contracting, what will happen is that there is increase in the left ventricular pressure. But more important in this, the blood is not going to the aorta, so there will be decrease in the aortic pressures. So you can see here. So this is the aorta denomination, this waves, and you can see here the aortic pressures has fallen post VPC, and all left ventricular pressures has increased, but the aortic pressures are decreased, and this is called as Broken-Borough-Braunwald-Morrow sign. So coming to the management part, so first, any patient of HCM you see, the first thing is you have diagnosed 2 parts is there. One is the symptomatic management which you do, symptomatic management, and second is the risk stratification. So coming to symptomatic, 2 things are important. One is medical management, that is with drugs, and next is the intervention management. So medical management comes up to 3 group of drugs. That is, first is beta blockers, that is non-vasodilating beta blockers. Vasodilators should be avoided. Vasodilator should be avoided. It should be a non-vasodilating beta blockers. So what does beta blockers does is that one thing of beta blocker is that it decreases the heart rate. So once if the heart rate is decreased, so there will be what will happen is that there will be more time for the left atrium to empty into the left ventricle. So more time will be there. There is increase in diastolic timing, diastolic filling time. So since more time is there for the left ventricle to fill, more will be the left ventricular stretch and opening. The left ventricle will stretch more and more, and it will move more away from the aorta. So this is the aorta. It will move more away from the left ventricular outflow tract, and thus there will be decrease in obstruction, and patient will feel symptomatically better. Also, beta blocker has what is called as negative inotropic effect. So what do you mean by negative inotropy is that it decreases the force of contraction. So if force of contraction is less, so this myocardium will move less towards the LVOTO, and then less will be the obstruction, and patient will feel better. Also, the beta blockers decreases the myocardial oxygen demand. So because of the decrease in heart rate, oxygen demand is less, and thus there is less chances of the perfusion demand mismatch. That is, supply demand mismatch will be less. So similarly, it is with next group of drugs are calcium channel blockers. Calcium channel blockers also works in the same way. So most commonly drugs are used is diltiazem. Verapamil is not used because verapamil has lot of vasodilating property. So and this vasodilating is not used. That's all. So why it is important is why the vasodilator should not be used is that suppose you do more vasodilation of this part, aorta, that is, it will lead to decrease in peripheral vascular resistance. So if there is decrease in peripheral vascular resistance, more blood will now empty easily into the left ventricular outflow tract. So this will lead to what is called as the left ventricular main volume will decrease, and now there will be what will happen is that the septum will come more closer to this LVOTO, and more will be the obstruction. So it will increase the gradient. So vasodilator should be, that's why it should be avoided. So again, going to the recommendations, that first drug of choice is always the non-vasodilating beta blockers, followed by non-dihydroprotein calcium channel blockers. And if at all patient is not responsive to that also, then you can use is diazepam. So what are the types of beta blockers? We want to use non-vasodilating beta blockers, that is metoprolol, atenolol, and propranolol. These are the non-vasodilating beta blockers. So suppose despite on all this therapy, if the patient is still symptomatic, after maintaining therapy at the maximum tolerating dose also, if the patient is still symptomatic, then you go for septal reduction therapy. That is either by alcohol septal ablation or by septal reduction surgery, or what is called as myectomy, septal myectomy. So let's go to it one by one. So intervention HOCM, most commonly now we're talking about alcohol septal ablation, where this was first performed by Sigvart in 1995. It is minimally invasive, and there is no surgical incision because it is basically done via arteries. So most commonly we use right femoral artery to commonly do that, and thus it have shorter recovery and hospital stay. So patient selection, what are the indications for alcohol septal ablation is that patient should be symptomatic despite on being maximum therapy. If the patient is symptomatic with NYHA 3 to 4, it is an indication for alcohol septal ablation. And there should be a dynamic left ventricular outflow tract obstruction. That is, the gradient should be more than 30 at rest or more than 50 mg with exercise or provocation. Also, the ventricular septal thickness should be more than 15 mm, and it should not be more than 30 mm. So it should be between 15 to 30 millimeters. So more than 30 millimeters, if the septum thickness is there, more than 30 mm, it is found that alcohol septal ablation is not very effective. For in this case, you have to go for myectomy, surgical myectomy. So suppose a patient also have any intrinsic mitral valve disease, or have patient is supposed to go any concomitant, any other surgeries. So if already patient is supposed to go any other surgeries, then always myectomy is better, because since the patient is already going for a surgery, it's always better to do, because myectomy is also invasive open heart surgery. It's always better that if a patient is supposed to go any other surgery, he should also undergo myectomy simultaneously. And suppose the patient age is more than 40 years, it is an ideal candidate for what is called as alcohol septal ablation. So why alcohol septal ablation should not be done in any patients with less than 40 years is that what we do in alcohol septal ablation is that we induce alcohol into the septal artery, and then we induce ischemia of the septum. So any ischemia, there is a chances that it will generate a scar. So if a patient is having ischemia, we generate ischemia at a very young age. There are high tendencies that in future patient may develop scar and scar VT. So it has been seen that any patient with young age, that is less than 40 years of age, if you do alcohol septal ablation, they have found to have a higher episodes of ventricular tachycardia or arrhythmias. So what should be seen things to consider before choosing alcohol septal ablation over septal myectomy is that also important is that the need for permanent pacemaker is 4 to 5 times higher as compared to septal myectomy. And also in alcohol septal ablation, there is some delay. Suppose what happens is suppose this is the septum. So now you have blocked the septal artery and there is ischemia. So initially what will happen is that this myocardium, if this is this much thickened, from here, because of the ischemia, for it to get thinned, it usually thinned and becomes scarred or become thin, or to decrease in obstruction, it usually takes around 3 months time. So alcohol septal ablation may not completely reduce the gradient very immediately. It usually takes 3 months time. So it has to be considered. Whereas septal myectomy, you remove a part of a muscle directly, and thus the reduction is very immediate. However, alcohol septal ablation takes 3 months time. So let's go into the procedure. It is done under conscious sedation. You have to give pain control because alcohol will generate ischemia, and this is ischemia will generate a lot of pain. So first step is to do a standard angiography. You do a coronary angiography because you need to know where the septal arteries are arising from and which septal artery is supplying the septum, basal septum. So usually in majority of patients, septal peripherals are arise from the left anterior descending artery. Next is that because the septal artery is being infarcted, there are high generation chances of right bundle branch block in patients with alcohol septal ablation. And also there are risk of complete heart block as well. So all patients undergoing alcohol septal ablation, you should have a temporary pacemaker in backup to prevent the development of complete heart block. So septal ablation frequently results in right bundle branch block that is seen in approximately 50% of cases. However, permanent pacemaker dependency from dependency of complete permanent pacemaker requirement is usually seen in 10 to 15% of patients, even with normal ECG. So suppose there is left bundle branch block or severe left axis deviation or a very cardiac QRS complex. If you do alcohol septal ablation, and this alcohol septal ablation will generate what is called as right bundle branch block. And if already there is LBBB, if you now put RBBB as well, patient will land into CHB, which is seen in around 50% of patients. But even with normal ECG also, there are 10 to 15% of chances of dependency of permanent pacemaker. Third step is that you have to pass the guide wire in the soft tip. So I'll just go to the procedure. So you have engaged the left, this is the left main coronary artery, and this is the left anterior descending artery. This is the first septal artery. So in the first septal artery, you have engaged with the guide. Now you have passed the over the wire balloon here. Now you have to confirm whether this septal artery is actually supplying the hypertrophy part or not. So how do you do that is that you inflate the balloon here, like without any contrast or anything, you just inflate the balloon here. Once you inflate the balloon, what will happen is that the perfusion to this part will go down. And suppose this septal artery, if it is supplying this myocardium of hypertrophied myocardium, what will happen is that since there is decrease in the supply here, so there will be what is happened, there will be stunning of this myocardium and decreased movement of this myocardium. And this will lead to decrease in LVOT gradient by around 30%. So suppose LVOT gradient has decreased by more than 30%, if the LVOT has reduced after inflating that, that means that you are in a correct artery and you should use that. Other way is that you send a contrast agent there. Usually we use is 20% albumin. You use 20% albumin, and if that is injected into the septal artery here, and you do simultaneously a contrast echo. The contrast echo will show, I'll show you here one minute. So contrast echo will show the staining of this part of the septum. So that means that you are in a right artery, and then you can plan for alcohol injection there. So which alcohol is commonly used is 100% alcohol is used. So this is also an important question which they ask, is how much alcohol is inserted, or that is usually 1 to 2 ml, and 100% of ethanol is used actually. It is inserted over 1 to 5 minutes with the balloon remaining inflated. So what happens is balloon should remain inflated. So over this wire, you can actually inject the injection, and main goal is that the alcohol should not get reflux back. Suppose the alcohol comes back into this artery, now there can be occlusion of this artery and the patient may land up with a massive MI, massive anterior wall MI. So you should be very careful that there should be no leak. And also when you put a contrast, or you after inflating the balloon, first you should give a contrast and try to see whether the contrast is coming back to the left this coronary or not. And also that contrast should not go to the right coronaries as well. Okay. So after alcohol injection, what will happen is that your patient should be kept on TPI for 48 hours, because if there is no arrhythmias or heart block after 48 hours, the patient can be removed from the TPI, that is temporary pacemaker. Results is there are 3 phases. One is the acute reduction in LVOT gradient, which is initially seen because of the myocardial stenting. Because initially what happens is that you have occluded the artery for some time, so there will be sudden blockages of flow and the myocardium will be in shock. So there will be temporary stunning will be there, so there will be decrease in the gradient initially. Afterwards, within 3 days, the gradients will come back to the normal level, and usually it takes 3 months for complete post-ablation, complete decrease in LVOT gradient post-ablation. So when the alcohol septal ablation is considered to be successful is that whenever there is a reduction in LVOT gradient to less than 30 millimeters of mercury in setting. Suppose the patients had a resting gradient of more than 50. Now if it is become less than 30, then it is said to be successful, or at least there should be more than 50% reduction. So what are the complications of alcohol septal ablation? These are all very important, again, because these are the common questions of examiner during the practical exams. They tend to ask what are the complications of alcohol septal ablation. Also, they ask about the percentages. So try to remember this image very clearly. That most common complication is RBBB, seen in 80%, and other complications are ventricular fibrillation, LAD dissection, pericardial effusion, complete heart block, as we have already discussed. And if there is spill of alcohol back, there can be large anterior wall MI. And mortality is said to be around 1.5%. Next, coming to septal myectomy, here nothing but we actually remove 5 to 15 grams of myocardium is removed and directly removed by the open surgery. So the mass is decreased and thus decreases the left ventricular outflow tract gradient. So patient selections wise, same. If the patient is refractory to drugs, then you should go for septal reduction or myectomy. If there is dynamic LVOT obstruction, there should be also, if there is significant, suppose the mitral valve is already diseased or patient is supposed to undergo any other open surgery, then always this is surgical myectomy is the first choice. And also in younger patient, because as we've already discussed, alcohol septal ablation can lead to ventricular arrhythmias, or because of scar VT on long term. That's why in less than 40 years, always surgical myectomy is indicated. Complications, complete heart block is 2%. It was seen around 12 to 15% with alcohol septal ablation. And myectomy usually develops left bundle branch block, whereas the alcohol septal ablation, right, RBBP is more common. You can develop VSD because if you have dissected too much part of the septum, there can be permanent VSD, and mortality is less than 1%, which is seen in 1.5% with alcohol septal ablation. So what are the factors to consider? Again, suppose if a patient is young patient, go for surgical myectomy. Suppose there is pre-existing bundle branch block. Suppose because ASA will lead to what is called as RBPP. So suppose if there is pre-existing LBPP, it's better to avoid alcohol septal ablation and you can go for surgical myectomy. So as I said, myectomy is contraindicated in patients with RBPP. Alcohol septal ablation is contraindicated in LBPP. And also alcohol septal ablation is contraindicated or not very useful if the hypertrophy is more than 30 millimeters. Also, if there is primary mitral valve abnormalities, then also surgical myectomy is the better choice. So let's coming to the last two topics, that is the pacemaker in HOCM and ICD in HOCM. So pacemaker in HOCM is a class 2B recommendation. So how does pacemaker is effective is that, so suppose this is the myocardium, this is the right ventricle, and this is the left ventricle, and this is the hypertrophic part. So normally during any pacemaker or pacemaking, the lead is kept in the right ventricle. So we keep the lead in the right ventricle. So now what happens is that now left ventricle will contract at its own beat, whereas right ventricle is being monitored by pacemaker. So there will be desynchrony. So right ventricle will be contracted at one time and left ventricle will be contracted at other time. So there will be desynchrony. So the contraction of the left ventricle may not be very effective because right ventricle contributes to around 25 to 30% of left ventricle contraction. So since if you remove the synchrony, that is if you make them desynchronous, what will happen is that the contraction of the left ventricle may not be very effective. If there is decreased contraction, there will be decreased movement of the septum towards the LVOT and there will be less obstruction. So that's why the pacemakers are used. So activation of RV apex, desynchronous contraction of IVS, reduction in LVOT gradient and short term. The recommendation is class 2B recommendation. Next, role of ICD in, that is defibrillator in HOCM, is that there are 7 points. This is a very, very important slide to be remembered because this is definitely asked if you get a case of HOCM in practicals or also in for the theory exams as well. This risk stratification is the most important question in HOCM. If you ask me, if you have to read one topic in HCM, if you don't have time and one topic you want to read and revise, this is the chart you should definitely read because this is very, very important. And based on this risk stratification only, we decide whether two patients should go for ICD or not. So most important is that suppose there is a family history. Suppose a patient of HCM, they have a family history of sudden cardiac death. That is, if any of the family member had died below less than 50 years of age suddenly, then it is an indication for ICD. Suppose there is massive LVH, that is, if the wall thickness is more than 30 millimeters, it is an indication. Suppose the patient developed unexplained syncope. There is no other explanation of syncope. It is usually think that it is because of the ventricular arrhythmias. And this is also an indication for ICD therapy. Suppose the patient have a LV systolic dysfunction. There is ejection fraction is less than 50%. Less than 50%, it is an indication for ICD. Suppose LV apical aneurysm is there or patient having a late gadolinium enhancement. Because as I said, suppose there is fibrosis of the heart. Suppose there is fibrosis of the heart. That means more chances of the scar is there. More chances of scar and more chances of scar VT. So if that composed of more than 15% of LV mass, there is high chances of ventricular arrhythmias and sudden cardiac death. And thus this is an indication for ICD therapy. And also suppose you do a Holter monitoring and you see a NSVT run there. That is also an indication for ICD therapy. So these are the 7 factors. In that, the class 1 recommendation is that suppose there are prior event of VT, suppose the patient developed a prior any event of VT before, or if there is family history, prior event is there, then it is a class 1 recommendation. Suppose patient have any of these following, like family history of sudden cardiac death, massive LVH of more than 30, unexplained syncope, apical aneurysm, EF is less than 50. This is class 2A recommendation. And if the Holter is showing NSVT or MRI is showing late cardiac enhancement, this is class 2B. That is may or may not be needing a ICD therapy here. A heart transplantation is usually indicated in patients with advanced heart failure and non-obstructive HCM if the EF is less than 50%. So next, coming to the main thing, that is a more important question, that is HCM versus athlete heart. Athlete heart, why do you want to compare is that hypertrophic cardiomyopathy will have asymmetric septal hypertrophy. Asymmetric, whereas athlete heart will have a symmetric hypertrophy. Also, in HCM, the left ventricular is of normal size. HCM. Whereas in athlete heart, because of the prolonged activity or exercise, what happens that LV is hypertrophied. LVH is predominantly present in patients with athlete heart. That is both concentric as well as eccentric LVH. And in HCM, left atrium is dilated because, as we already discussed, that there is poor compliance of the left ventricle and mitral regurgitation is there. So thus, there will be dilatation of the left atrium as well. And very most important part is that suppose the athlete stops doing exercise for 3 months, the left ventricular and everything, all these changes of the athlete hearts will become reversed. So let's go to all the points. In athlete heart, septum is usually less than 15 mm. There is symmetrical thickening, no family history, and usually resolves with deconditioning, that is 3 months. So what are the emerging therapies is there? Now, other than alcohol septal ablation and also with surgical myectomy, we have also radio frequency ablation, which is coming latest in that. So always remember, while writing any answer in an exam, suppose HOCM or anything, most important thing is that you should try to mention updates, latest updates and trials as much as possible. So if you write updates and trials in your exam, so this will have a very good impact on your score. So always try to write about latest updates, whichever is there, or latest any guidelines which has come up, or trials into your answers. So similarly, in radio frequency ablation, we do ablation of the myectomy, that is a septum, by using a radio frequency, that is RFA. Last drug we have to remember is mavacanten, which is being now given a class 2B recommendation, that is it may or may not be used in patients with HOCM. So how does it work is mavacanten is an allosteric inhibitor of cardiac myosin ATPase. So that means that suppose this is an for muscle to contract, there is actin and there is myosin. So this actin myosin contraction coordination is very important. So this, if this myosin, for this to happen, myosin ATPase play a very important role. So now what does mavacanten does is that it inhibits this ATPase. So there is decrease in interaction between actin and myosin. Thus there will be less contraction, decreased contraction of myocardium, and thus there will be decrease in gradient. So this has been seen in 2 trials, that is Explorer HCM trial and Whaler HCM trial. So you can read this because we have a time constraint. We may not be able to discuss everything here. So Whaler HCM trial and Explorer HCM trial are the 2 important trials for mavacanten. So which has a very important role. And the last thing is the gene therapy, which is being emerging therapy, which is being studied now. So that's all, guys. I think I have covered everything. If you have any queries, I am ready to take it now.
So, Babdeep, please go ahead. Please unmute yourself first, and then you can raise your question.
Yeah. Hi, Lavdeep. You have asked about the pacemaker. So role of pacemaker, see, it is in HOCM, has 2 roles. So if you talk about pacemaker, one is only for the symptomatic benefit. So what happens in pacemakers is that, as I told you, so if suppose you take this as the heart and this as the right ventricle and left ventricle. So both our right ventricle and left ventricle are interdependent. So no matter we say that right ventricle is contracting, left ventricle is contracting, some part of the left ventricular contraction is contributed by right ventricle and some part of the right ventricular contraction is contributed by left ventricle. So in both RV and LV normally contract in synchrony. That means both of them contract simultaneously to have an additional role, like they support each other in during contraction. Now what you do is when you put a pacemaker, you put it in the RV lead. So RV lead, now right ventricle is completely being in control of the pacemaker, whereas left ventricle is being contracting based on the action potential it receives. That is SA node, AV node, or whatever potential it receives, it contracts based on that. So there is some dysynchrony. Now right ventricle is contracting independently and left ventricle is contracting independently. So the amount of generation of left ventricular contraction is reduced because, as I said, right ventricle contributes around 20 to 30% of LV contraction. So since RV is now desynchronized, it is not participating anything in the LV contraction, this amount of contraction is reduced in LV. So since the LV is less contracting, as I said, suppose this is the outflow tract. If this part is contracting less, suppose it contracts more, it will block the left ventricular outflow tract here. So if the contraction is less, the amount of outflow tract obstruction will be less, and thus there will be symptomatic benefit. Another role of pacemaker is, as I said already, in alcohol septal ablation, or if you do surgical myectomy, during a alcohol septal ablation, there are chances that 10 to 12%, 15% of patient will develop complete heart block. So to prevent that, we use pacemakers in that, but it is a temporary pacemaker, and very less chances is that they may need a complete, like, permanent pacemaker action. So these are the two roles of permanent pacemakers or pacemakers during in HOCM. Yeah, I hope this is clear, Lavdeep.
I'm seeing Ashif raising hand. Ashif, please go ahead.
Effect of Valsalva on HOCM murmur.
Hello? Yeah, I didn't get your question.
Effect of Valsalva on stages of Valsalva on HOCM murmur.
Valsalva, okay. See, I'll make a separate video on that. Valsalva itself will take a lot of time. Don't worry, I'll make a separate video on that and upload you. It will take, like, to complete all the phases and all. If I want to explain, it will take another 15 to 20 minutes. I'll make a separate video and upload it in the group for that Valsalva on HOCM.
Anyone can have any question?
Triple ripple apex apical impulse explain in HOCM patient.
Okay. Yes. So I think this part I didn't cover. Apical impulse in HOCM. So classically in HOCM, there are three types of apical impulse which is described. One is the normal apical impulse, straightforward. The normal apical impulse is seen normally during systolic contraction. And during systolic contraction, what will happen is that this apex will be touching the precordium, and that is detected as an apical impulse. Like, we feel it as apical impulse. The common thing which is seen in HOCM is double apical impulse and a triple apical impulse. So double apical impulse is that now the patient will have two apical impulses during systole. So why does this happen is that, so suppose you take this as left ventricle, and if this, you consider it as the outflow tract. So initially, when the left ventricle is contracting and during systole and sending the blood to the aorta, So during this early phase of systole, there will be first apex will be touching to the precordium, and you will get a first apical impulse. And as we know that in HOCM, it is a dynamic auscultation. That is, sorry, dynamic obstruction. So dynamic obstruction means what? That now when the left ventricle has emptied some amount of blood into the aorta, now what will happen is that the stretch to the myocardium is reduced. Now this septum will go more closer to the left ventricular outflow tract, and this will obstruct this part. So now to overcome this obstruction, the left ventricle tries to contract in even with more intensity. So when this left ventricle try to contract even with that is the second phase of left ventricular contraction, this will generate another apical impulse, which is called as double apical impulse. So first during normal contraction and second against this resistance. So there will be two apical impulses which will be seen, and it's called as double apical impulse. And also there is called as triple apical impulse. So triple apical impulse is nothing but that is 2 is in systole, as I've already discussed. There is 2 apical impulses here, and 1 apical impulse will be seen during diastole. So what will happen in diastole is that, so as we are all aware that in HOCM, left ventricle is non-compliant because of the stretch or load in it. There is diastolic dysfunction, or directly to be said, there is relaxation defect. So since there is defect in relaxation, what will happen is that this atria will during its pre-systolic phase. So like in atrial contraction, atrial in diastole, there are 4 phases. One is early filling, that is early filling or early emptying. So initially this valve opens and the atria tries to empty here. Then there is diastasis phase when there is even flow of blood, and last is the atrial contraction. Now in HOCM, what happens is that since there is a lot of resistance here, the amount of blood flow from the left atrium to left ventricle during these 2 phases is very less because of the non-compliance of the left ventricle. So all the blood when it has to empty, now empties during this atrial contraction phase. So whenever this atrial contracts and empty blood into that, it forces the blood into the left ventricle, which makes the left ventricle apex to go to the precordium, and it produces what is called as third apical impulse. And this is called as triple apical impulse. So which is classical of HOCM. So that is 2 in systole and 1 in diastole. Hope I have cleared it.
Yes, sir. And in alcohol septal ablation, 2 ml of ethanol when we give, then we have to push through saline also to over the wire balloon, or just only 2 ml?
No, just only the 2 ml of ethanol.
And how will it reach? We have to push something to reach there.
No, actually what we do is we keep that balloon inflated. So there is, it is over the wire balloon. Na? So what happens is in the 1 minute, I'll show you this. So okay, so here you can see. So what will happen is that once we check with the over the balloon inflation here, so during injection also, like drugs will go down. It may not, but it will not be able to come back if the balloon is properly inflated. So we have to inject the alcohol only during whenever this balloon is completely inflated. Then only the alcohol has to be injected. So there is no way this alcohol will come back to here, and it will go only in this direction only now. So that's why we inject only alcohol, and that's why we say if there is a spill is there, then there can be development of anterior wall MI during this process as
well. Okay. The 2 ml, if pushed, it will remain in the balloon lumen, shaft lumen, or it will reach there.
No, it will reach this balloon. Even if the balloon is inflated, when you give injection, they have a pores here. It comes down here. It will not back leak, but you can give drugs in downway here.
Okay, sir. Yeah. And role of coiling in septal, like through wire, putting wire and necrosis of the septal artery. What is the role?
Rule of coiling, as of what I know, I don't think coiling is recommended for HOCM as of now, but I'm not very sure. I'll go through it definitely if it is there. I have never heard of coiling in HOCM as such. I will definitely clear it whenever you, since you have asked it, I will go through the literature. I'll try to clear it for you.
And sir, pulse in HCM versus AR, how to differentiate?
Pulse in HCM versus AR using.
Bifid pulse, both percussion wave and tidal wave.
Okay. I think I will take that very clearly next time, because again it will take some time. So don't worry, I'll cover that in our pulse examination topic whenever I say that.
Okay,
Or I'll
thank
upload it
you.
by 1 or 2 days. Give me a couple of days for that, because it again will take a lot of time to explain that.
Okay, sir.
Yeah, okay. Don't worry, I'll post it in the group. You are there in the group, I guess.
Okay. I hope sorry. Someone has got some question.
The role of screening echocardiography in patients of familial HCM versus patients who are have not detected HCM. What is the average screening? Is there same screening time, or the time interval is different between
The screening part you're talking about, no?
Yes.
I just rushed through that. See, the screening, what they say is it differs for the patient with genotype positive, and it's different for patient with who are genotype negative. So suppose for adult screening, if you're saying, so if in adults, if any patient is diagnosed, in any of the family member is diagnosed with HCM, then you have to do screening every 3 to 5 years.
Okay.
Okay. For children, suppose you are talking about pediatric children and adolescents, from if they have genotype positive. So since the time when any of the family member is diagnosed with HCM, you have to do echo every 1 to 2 years. And if genotype negative it is there, then you have to do it every 2 to 3 years.
Okay.
Okay. Considering the time, we have to wrap up this session now for today. But if you guys have any questions, please drop message on the group. Yeah, thank you everyone for joining today. Yeah, thank you, Dr. Doctor. Take care.